This is my answer, Dr. Kaltan.
Thank you, doctor.
Thank you.
And Dr. Diyari?
Yeah, good evening. Thank
Good
you, Dr.
evening.
Omi, Dr. Walid. Thank you very much for this nice presentation. Dr. Omi, just regarding your first presentation, your first case. Now, 10 days on ceftriaxone and clindamycin, and continuously the patient having fever. So when you are thinking to after how many days of continuous fever, you are going to change the antibiotic?
It all depends on like what antibiotics we have started with. As I said, our first line antibiotic for community acquired pneumonia is penicillin derivative, and generally coamoxiclav is more than sufficient. And majority of times I would treat them for 5-7 days to see the response. Now, if they have had already given in the community before they presented to us, then I might change the antibiotic, considering if the inflammatory markers are going up as well, or the clinical picture is changing, they're hypoxic, they're requiring oxygen, they're tachypnic, the chest x-ray is getting worse, CRP is going up, procalcitonin is high, then my threshold for changing antibiotic can be a bit early. As in day 5, I might be able to changing that. Or if I see that the pleural effusion is getting worse. So there has to be some other markers along with fever that will tell us. But if there is only marker is fever, I know that it's not settling down, but clinically the child is well, no other stigmatas, not oxygen requirement, it's just fever, then I might sit slightly longer to see, okay, instead of 5 days, I might sit for 7 days before I change it. And if we are changing it, then the second line I would go for is slightly broader spectrum, and it could be, and many times if we have like, if they have been on oral antibiotic and we are changing, sometime we might change from, we might go to cefuroxime or ceftriaxone just once a day, although cefuroxime is much better for respiratory pathogens. But we have to think about so many practical aspects. The cannula tissue when you're giving 3 times daily, and simple things like cannulation becomes a challenging task for children. So you give ceftriaxone once a day, similar kind of spectrum works better. And clindamycin we will only add if we are suspecting that there is some pleural effusion there, which might have better kind of penetration in the effusion, might have better coverage with Staph aureus. Vancomycin is not our preferred choice even in the beginning. I would only change it if we are not seeing the good response with clindamycin and ceftriaxone. So it depends. What the short answer is, it will depend on so many other factors. What antibiotic they were taking first, clinical picture, other markers, x-rays, ultrasound, inflammatory markers.
Sorry, I would like to interrupt. I've got some urgent work. I have to leave. I would like to thank Dr. Wali, Dr. Omi, and all viewers, Sophie Fadi. So Dr. Kalpana will take over. Thank you very much and good night.
Dr. Sohrab, thank you, but you cannot leave. He cannot leave, right? Yalla, okay, that's fine. He's a nice guy. He can leave.
You can leave.
Dr. Omi, one question. How much time will it take for Mycoplasma IgM to become positive in serum?
It can take up to 2 weeks. It can take up to 2 weeks to become positive. So you might not see in the first few days, first 5 days. But also we know that there is no rush of treating mycoplasma in the first 5 days, because it might not be mycoplasma. That's what I'm trying to explain. That unless you are suspecting that this is mycoplasma, you don't have to rush into treating. But yes, the serology might not be positive for 2 weeks. So you might have to start the treatment before, because not every center will have the luxury of doing a respiratory viral panel. You might not get insurance approval. You might not get a sputum sample to check for PCR, and all these tests are expensive. So, to justify in outpatient as well in clinic setting is harder. When they get admitted, then the justification is there. But in clinic setting, it can be much harder, getting hard to get approval from insurance as well. And not all hospitals might be able to do it, even if the child gives you a sputum sample.
The etiological diagnosis is definitely important in the cases that get admitted to the hospital with these kind of pneumonias. Definitely, a lot of children in the OPD we see, and they really are treated empirically, and quite often azithromycin is used in these children. So, like Dr. Pankaj had a question, is that leading to increased resistance? Another doctor wondered whether in the first case, the use of clindamycin before using treatment for mycoplasma, whether that led to resistance. So
Regarding the first case specific, like it's very hard to say. Like, I wouldn't assume that using 7-8 days of clindamycin will lead to resistance of mycoplasma. I wouldn't have thought so. But overall, in general, kind of a lot of usage of macrolide has led to resistance of mycoplasma. That we know. Azithromycin is used like Smarties for most viral infections. Even if there is some virus on the PCR, on respiratory viral panel, just in case, we give it for 3 days, once a day, 3 days. Yeah, inadvertent use of antibiotic is going to lead to macrolide resistance. So yeah, that's my thought. I don't know what Dr. Walid agrees or not.
I'd also like to ask Dr. Walid, sir, what do you think is the role of the local antibiograms? Should we be looking at those? Should hospitals be, making them available to the clinicians because so that we can do appropriate treatment?
This is very good, Dr. Kalpana, but as you know, to culture mycoplasma, we don't do cultures. And to run susceptibility, we have to do the culture for mycoplasma.
Not only mycoplasma,
And
doctor.
huh?
Not only mycoplasma. I'm talking in general.
Every hospital has antibiogram by law. Every hospital has antibiogram, and more or less the same for UAE. We know we have national antibiogram and we have local antibiogram. Of
So we
course, it
should be
helps.
looking at these, right?
Huh?
So they
It
are very
helps.
helpful. The microorganisms may change over time, the resistance patterns may change over time. So once work is being done and they are available, it's our duty to look at them and treat appropriately.
Absolutely, annually, antibiogram will be generated for every hospital, as well as national. There is a national committee for looking at the antibiogram. But again, otherwise, if you clinically thinking that your patient, this is on the merit of the case that, maybe this is resistant, then you will ask the lab to run susceptibility for that patient. But and any culture, usually there is sensitivity or susceptibility, whether staph or strep, or usually you have the susceptibility results for that patient. Unless you think, there is a glitch in the machine that it is susceptible and you are treating and it's not responding, then you will call the microbiologist to double check. Maybe they can do what's called Kirby Bauer susceptibility test or the disk dilution rather than the machine. It used to happen once in a blue moon, and I have to call the microbiologist, and there was an error in the machine. But this is very rare.
Dr. Walid and Dr. Omi, all these patients we heard about respiratory panel and even pneumonia panel. So what are the indications for respiratory panel and pneumonia panel and when you are doing it?
I'm sorry, yeah, go ahead.
Dr. Walid, you go ahead.
No, go ahead, please.
I was saying that in terms of if they are coming in clinics or presenting an emergency and you suspect that this is a viral illness, you don't necessarily have to do it. If the presentation is recurrent, that they have not responded, you have done your safety netting, and they have presented back in 2-3 days' time, ongoing symptoms or worsening of symptoms, then it's justified to do it. If I'm admitting a patient with pneumonia as a primary symptom or primary diagnosis, then I would like to know. Because not only in terms of prognostication, that what we are treating, I don't want to use too much of antibiotic. I don't want to use, for longer. And if it is just a viral illness, then we will not use antibiotic. We will, many times we have children on intensive care, and people are worried that they are on ICU. But if it is a clear viral illness, whether it's RSV or rhinovirus, I would not use antibiotic. We might, if they have got ventilated for 2 days, we might use it for 2 days and then stop it early if there is no other suspicion, nothing else positive. So unwell cases, admitted cases on ICU, or if there is a recurrence, persistent symptom, then I would use.
You know, the downside of this, Dr. Omandra, you know, these are not really pneumonia panel. Pneumonia panel, when you have deep tracheal aspirate, patients on ventilation, and you do deep tracheal aspirate, and then you will do the pneumonia panel. Or older child, he can cough and produce sputum, good sputum, not saliva. But what I have seen, you know, pneumonia panel, and it is saliva. How you can do pneumonia panel for 3 years or 5 years or 4 months? You know, this will mislead the treating physician, because this is our colonized bacteria in the throat, and will say this is pneumonia panel. It is not. I don't recommend to do pneumonia panel unless the patient intubated, and then you will take deep tracheal aspirate, and then it gives you, or older child, really he can cough and produce good sputum, not saliva. Unfortunately, 90% of the pneumonia panels done, they are saliva. And I talked to Dr. Rubina in our hospital, please discard this pneumonia panel, discard it, unless it is ET, or kids, they have tracheostomy and there was secretion, or older child and induced sputum, and it is a good really specimen. Otherwise, it is waste of cost, and this will mislead the physician to give the wrong antibiotics.
100% agree, Dr. Wise. If you remember, I emphasized that it has to be
Yes,
children
yes,
on sputum or lavage or ET samples, or we do have the luxury of,
yes,
like,
yes.
very
I
experienced
I
respiratory
remember this.
therapists,
Yeah,
and
yeah.
we can get induced samples in slightly younger children, but these are all sputum samples. If we see that the quality is not good, either we will not send, or the lab will reject that this is saliva and not sputum. So
If
yes,
you remember, one of your cases grew Haemophilus influenza and Mycoplasma PCR and another bug.
Tough.
These are
Tough audience.
colonization of the throat, you know, not really.
Yeah, interpreting these is not easy. We get multiple organisms
Yeah,
and they
yeah,
don't
you
make
know,
clinical
throat, you
sense.
know,
that's very, very common, even on the
yeah,
respiratory
you
panel.
will have 3-4 positives, you know, for this.
Correct.
Yes. There are two more questions regarding mycoplasma related to the age. There is like, is age a bar for mycoplasma? Do you think that in older kids we should, if suspected, empirically treat them, Dr. Omi?
I mean, I would have a lower suspicion for mycoplasma pneumonia in older children than in younger children, and that's absolutely true. Whether we should do empiric treatment, I'm not for it, because empiric treatment for anything is not good. Even if they have mycoplasma pneumonia, they might improve by themselves. So if you are doing safety netting, as in bring them back in 2 days' time, explain parent that these are the things we are looking for. If they go downhill, yes, definitely we will treat them. But I know that we all have extremely busy practice. We want to be safe. We don't want to, and parents as well, when they're worried, then you feel that, okay, 3 days of antibiotic might not do any harm. It might do benefit. And we all are culprit for that. But then we are contributing toward the macrolide resistance.
Right.
You know, again, my dears, I don't want our audience to go with the home message that Mycoplasma pneumonia is common and very complicated and resistant, and we have to, those cases seen in, I would say, like tertiary hospital by consultant pulmonologist, complicated cases, exhausted the usual treatment. But we know Mycoplasma pneumonia is still working pneumonia. These are exceptional cases. And if they reach to this stage, I recommend to consult the pulmonologist and the infectious disease to look at this case.
Agree.
Right. Dr. Bali, the two of your cases showed signs of systemic inflammatory response syndrome. Dr. Nilesh mentioned they look more like Kawasaki, and you gave IVIG. Was steroid also given, or could IVIG have been avoided if it was not Kawasaki-like picture? Would steroids
No,
help
these
more?
cases not Kawasaki. They didn't have any features of Kawasaki disease. So, and COVID antibody was positive on these cases. I didn't have time to finish my slides. There was very good, interesting article about changing of RSV epidemiology after COVID-19. And the explanation for this, and this is not, I'm telling you, this is not only for RSV, for all the viruses. The explanation that, this is hypothetical because the children were protected for 2 years from having those respiratory infections. The immune system is really not that strong to fight. This is one hypothesis. The other hypothesis that, those viruses collaborated together with the COVID-19 and there is change in the genetic of these viruses, or the COVID-19 has dysregulated the immune system as a blank statement. So those viruses becoming really nasty and aggressive because the immune system already got dysregulated.
Yes. Doctor, maybe we can, go deeper into this discussion still on our social media platforms. It would be nice if you could maybe post the link so that in the larger interest of the audience, because definitely we have also seen at our levels more invasive infections this year with RSV. The second thing is that, like Dr. Omi mentioned, the guidelines, they don't even talk about doing CRP and PCT. Whereas I think almost all of us do those and they do help us in this. Having said that, it's not only the bacterial infections that give us this really high inflammatory markers, and even PCT for that reason. In adeno, everybody knows that we get these to be high, but even other viruses, human metapneumoviruses, we have noticed. I don't know whether you all have similar experience. So your point is well taken that COVID seems to have changed something that has led to this kind of situation.
This is what I have been saying for many months, and Dr. Diari, maybe he listened to my statements. I think we have to go back and relook at our old guidelines and
Yes.
pathogenesis of these infections. No more, it is the same before COVID-19. No more. Things changed.
Yes.
And from my daily encountering with infectious disease, I'm seeing different diseases, the same organism, but with different presentation, with different labs, with different systemic inflammatory response syndrome. So really we have to be vigilant. And I think we have to go back and relook and revise our guidelines. And this will be based on studies and meta-analysis and research. Because people will say, this is your personal experience. But if there is really good research, I think we have to review all our guidelines and update the guidelines.
Right. Dr. Iyad wants to know, in your second case, Dr. Walid, how long will you continue clopidogrel for?
What second case?
How the child was on clopidogrel, how long will it be continued?
Till the dilatation resolved. till the ectasia, and sometimes it takes 1 year.
And for your third case, you mentioned that you would not have preferred cefuroxime to be the antibiotic. What would you have started instead of cefuroxime?
Okay, you know, so if you're again, this is if you think of pneumococcal and the patient who has really respiratory distress and requiring oxygenation, ventilation, nasal cannula, and back to Dr. Diari and Dr. Omendra, clindamycin has no place. Excuse me, Dr. Omendra, for this. If you think of Staph aureus, clindamycin has no case in complicated pneumonias. This is one. Vancomycin will be given till I make sure the bacteremia is not there. I usually go to linezolid. Having said that, it is not, this is written in stone. I may start with the clindamycin and ceftriaxone and see the response. Why is that? Because back to Dr. Kalpana, our antibiogram showed that with MRSA, we have MRSA around 30% in the community here. And for clindamycins, it's around 16%. So the recommendation that if clindamycin resistance in your area more than 10 or 12 in severe cases, clindamycin should not be used. This is the point. So cefuroxime, if you think of MRSA, it is obsolete. I'm talking before knowing that it is MSSA. I'm talking that if you have a baby with 6 weeks or 7 weeks with pneumatoceles and develop pneumothorax and respiratory distress, I will not give cefuroxime. I have to consider MRSA. We know MRSA, all of these are obsolete, becoming obsolete. So cefuroxime is not good. People trained in England, and this is why people using cefuroxime, because when they came here in England, MRSA was not an issue. And cefuroxime is used on a daily basis. That's why we have to consider our local antibiogram.
Dr. Reed, a lot of questions about your last case. So
About
they are
what?
asking what's his situation now, and if the last case, the one on ECMO, what is the situation now?
It is very poor prognosis, in critical shape. The immune system is not working. Nothing we could do except for supportive and
any immune deficiency?
Any immunodeficiency?
Immune deficiency, Sir Walid? Immune deficiency?
He's not immune deficient. He's completely healthy. We did immunoglobulins, we did lymphocyte subsets. Immune deficient, he's immune deficient currently.
He's immune
No
deficient.
way. He's immune deficient. Though I gave the IVIG and he has IgG, this to counteract the systemic inflammatory response syndrome. But functioning, why he's not lymphopenic? His immune system severely dysregulated. And by the way, I have another patient, similar case scenario next to him. She's 5-year-old, influenza A, pneumonia. She was okay. Inflammatory markers were high, given IVIG and methylprednisolone in other hospital. COVID-19 positive. She improved a little bit, and then she developed severe ARDS and multi-system organ dysfunction. Almost similar case scenario, but this time I would say we treated the biological treatment early in the course and anakinra, and just I went here, stopped anakinra a few days ago. Still critically ill. She was about to be on the verge of ECMO, but she is still hanging around. Hopefully she will recover. It's the same case scenario. And developed infections and fungal infections. Yes.
Okay,
So
your
what-
third case was COVID positive and RSV positive and blood culture for Klebsiella pneumoniae also positive.
Yeah.
So
You know,
you
I mentioned the theories, COVID-19 dysregulated the immune system. Whether it is MISC, pure MISC, and influenza B, it is coincidental, or the immune system got dysregulated and influenza triggered again the inflammatory response syndrome, or combination, and bacterial infection secondary. And by the way, influenza PCR till now positive. She has been here for almost 2-3 weeks. So there is we got very good article about cytokine storm and immune paralysis. Cytokine storm and immune paralysis. So if you search it, it's really nice, you know, because the immune system will be dysregulated, shut down, and patient will be prone to all multi-organ dysfunction, cytokine storm, secondary bacterial, secondary fungal. And so I have to treat him as severe immune combined deficiency syndrome. And patients both are on Bactrim high dose prophylaxis for PCP and fluconazole for once they are off treatment for candidal infection, they are on prophylaxis.
So it is more the host factor rather than the
Very good,
virulence
Dr.
of
Kalpana. It is host response, because if you see this twin, girl and boy, the boy, he developed very stormy course. The girl, she's fine. Both they had COVID, both they had influenza A, but the boy, this is ended in this situation. The girl doing well.
better.
As if you recall, we published case from, not case, an article in Al Jarida in Pediatric JAMA about MISC and kids developed COVID, the treatment, and we did whole exome sequencing, and we found those kids with MISC that developed MISC in comparisons to children who didn't develop MISC. They have more genetic variation, putting them at risk of what's called cytokine storm.
Yes.
So I agree with you. Most probably this is genetic predisposition.
Okay.
a question: what's the role of vitamin D supplementation in treating pneumonia?
Well, I never used that vitamin D for pneumonia.
Vitamin A is the question.
I
Vitamin
use
A.
vitamin A in measles.
A.
Yeah, but vitamin D, I don't. However, routinely, this is very good point, Dr. Diari. Routinely for those sick patients, like those 2 cases, usually I check the level. If deficient, I give them a treatment, not supplement. If they are okay and they are on steroid, it is mandated to give them the supplement daily. So this is the role, but not pneumonia for the systemic inflammatory response syndrome.
I think there was a question about empirical Tamiflu, use of Tamiflu.
Given, I gave both of them given Tamiflu. Empirical, I will not give every viral respiratory infection Tamiflu.
Exactly.
Unless there is an index case and the sibling or the father, the mother
Sibling.
developed, I will give Tamiflu. If I have to give, I have to test for influenza itself, not PCR, as Dr. Armando mentioned, not respiratory panel, or Dr. Diari mentioned. I will do specifically influenza positive, I'll give Tamiflu.
And similarly, there was a question that if there is an index case of mycoplasma in the family and sibling develops similar symptoms, would you empirically treat that as mycoplasma?
You know, I will make sure, you know, the other, what symptoms or infection, what symptoms, does it fit mycoplasma or not? Because to be honest with you, people, they don't test mycoplasma for patients at home. or the index case in the hospital and the other sibling developed mycoplasma. This is a hypothetical case scenario.
Yes.
So if conferred mycoplasma pneumonia and the sibling in the hospital and the child developed symptoms similar or, clinically case definition could be mycoplasma pneumonia, I will give the empirical treatment rather than to do PCR or serology, and they are not helpful. By the way, if you have 100 children, you do mycoplasma IgM, 70 will have positive.
Positive, exactly. And once positive, it remains positive for some time as well. Right?
It will remain positive for a few months.
And
The
mycoplasma,
worst is the serology for mycoplasma, and the worst also, so PCR also can stay for a while because mycoplasma could reside in the throat for almost 3 months. So isolating PCR, they say the best combo is PCR and serology. And they also added IgA. Also, it will be IgM, IgA, and IgG. If you would like to do the serology, and you have to do paired sera in convalescent stage, but this defeats the purpose, to treat or not to treat. This is for academic reasons, not for treating that particular patients.
And Dr.
Yes,
Omi,
if you encounter cases similar to Dr. Omandra, I will do PCR and serology together. If you have IgM positive, mycoplasma positive, and for academic interest, and I will repeat the serum in 3 weeks for both IgG and IgM and see if there is fourfold increase or decrease. This is, I can stamp, this is mycoplasma pneumonia.
Dr. Omi, as a pulmonologist, what's your indication for CT scan chest in the pneumonic cases?
very simple. It's like if we are planning for any surgical intervention, that means we are planning for VATS particularly, then we would like to know. Or in unresponsive cases where we feel that the complicated pneumonia is leading to lung abscess, then we would do it. Just for consolidation or parapneumonic fusion, we will not do it.
And Dr.
The case is empyema. You are looking for empyema, isn't it?
So for
ultrasound.
Yes.
Ultrasound will be good for empyema and escalated empyema. As Dr. Omandra mentioned, if you are planning for surgical intervention, the surgeon recommends CT scan.
So suspected lung abscess.
Yes.
Yes. Then I would do it, because then I don't want surgeons to go in there because the role is not there. We can manage them conservatively. Or if we are particularly thinking of VATS, then the surgeon would recommend that to do it for anatomy, but not for diagnosis of empyema. Ultrasound is the investigation of choice to look for septation.
Yes.
One more question to Dr. Omi from Dr. Mohammed Husni. For first case, is it possible that patient had microscopic polyangiitis, which can explain wheezing and eosinophilia? And did the patient develop interstitial nephritis because of pipistrellin, because of eosinophilia? So what was the eosinophilia due to?
Yeah, I mean, not the typical age group of polyangiitis. So we normally see in more teenagers, and generally, again, they don't respond to your normal steroid dose that we are using in asthmatic, 15 milligrams or 20 milligrams of steroid. They need high dose, and there was no evidence of nephritis in that case.
Right. There was one question from Dr. Sohrab, coming from both of you. Which are the cases where cases of pneumonia where you will not use antibiotic?
You will not use what?
An antibiotic.
Okay. If this viral infection, you will not use antibiotics.
So if you are sure it is only RSV pneumonia, you will not use it, say, for
You
example.
know, what happened here? I don't know. Not looked in.
Nothing. We can't hear you, Dr. Walid. We can't hear you.
Can you hear me?
Yeah,
Yes,
yeah, yeah.
yes, doctor.
Yeah, you know, if this clearly straightforward viral infection not requiring admission. If a patient, even documented influenza or RSV, if it is complicated pneumonia requiring oxygen, respiratory distress, it is very hard to
Not
say this is a purely viral infection. That's why everyone will use antibiotics.
exactly.
Last year we had same thing with adenoviral, right? Last year we had peak of adenoviral pneumonia. There was nothing else positive, but 7 days, 10 days of fever and child is admitted, there you end up using antibiotics because you're
Exactly.
worried that secondary complication might be happening.
By the way, maybe Dr. Diari is aware about this. We had adenovirus, purely adenovirus, I think with COVID or not COVID. He was an ECMO and he could not make it for 2 months on ECMO.
Oh.
But again, we are tertiary hospital. We receive the most complicated, the most sick patient. I don't want to say, you know, all these cases similar. But if you encounter such case, I really recommend to transfer the patient where you have all the subspecialties around you. You have really intensive care unit. ECMO is available because those patients easily can require ECMO.
Yeah, point well taken, doctor, but it helps to know the severity of the cases and the cases where we get stuck, those who are not improving with the, first line, second line treatment, then
Transfer
probably
the
we should
patient.
start.
Wallah,
Sorry,
transfer
yes,
Third line,
doctor.
Jalil.
Yeah.
Dr. Walid is their third line.
Third
Dr.
line.
Walid
you know,
accepts very easily,
I never
but not
say
Jalila
no.
Hospital.
I never say no. I never say
But
no.
not your hospital, doctor. So, yeah. Thank you very much. I think that brings us to an end with, I think we have covered the spectrum. Very good discussion. And I really thank you both for wonderful cases. And, we've gone deep into this. We cannot say we have covered the whole of pneumonias. That's not possible. But we've touched many important aspects is what I would say. So thank you so much, doctors, for being a part of this webinar. And Dr. I would still request Dr.
Have a
Walid,
nice weekend.
You know, I would like again to thank you, Dr. Sahrab. I'm not sure he's not. I'm sure he's not sleeping. He usually stays till morning. Dr. Kalpana, Dr.
He never sleeps.
Mr. Tawfiq, Mr. Fadi, my dear friend, I enjoyed so much your cases, the presentations, the discussion, and also many, many thanks to our audience who attended our webinar. And I enjoyed it so much, Wallah. Thank you.
Thank you.
Thank
And
you,
we
Dr.
also
Walid.
thank Dr. Saurabh for his initial talk and Dr. Diari for moderating the
Thank you,
session with
Dr.
me as well. Thank you.
Thank you, everyone. Thank you so much.
And see you all in the next webinar.
See you
Thank
soon.
you. Thank you.
Bye.